to this presentation on bronchiolitis for the Acute and Emergency Paediatrics module for MDM 158 of the Master's Programme at BSMS in Child Health and Paediatrics. My name is Carmel, and what I'd like to do today is share with you the story of how we succeeded in pushing the boundaries in managing patients with bronchiolitis over the last 5 to 7 years here at the Royal Alexandra Children's Hospital. And bronchiolitis is the most common reason for PICU admission in the Western world, and we thought we had an opportunity to affect how many children were escalating to invasive ventilation, and to try and reduce this, to try and reduce the numbers of children being admitted to PICU from our hospital. And this essentially is how we went about doing that. So I hope you enjoy it, and thank you for listening. So we saw the opportunity to reduce intubation and PICU transfers in infants less than 2 years age with severe bronchiolitis, and we kind of thought about that back in 2012. So on this slide, I'd like you to first go to the bottom left and have a look at that picture, because I want you to remember, and it's also to remind myself, that when we tell a story about how we might have succeeded, and particularly if you're going to use something like PowerPoint, the linearity of PowerPoint, the way our brains also try to make sense of what's happened, particularly when we look at things in retrospect, and the way our brains like to think of a story, we often will look at things in a very linear kind of way. The reality actually is way more convoluted. There's chance, there's learning, there's development, there's mistakes, there's evolution of our leadership styles, how we decided to teach and learn, all goes into the melting pot to make the success actually a lot more convoluted. So just bear that in mind as we go through this story. So now I'd like you to just look at the top left-hand bar chart, which shows the number of children under the age of 2 with bronchiolitis that we treated in our paediatric critical care unit at the Royal Alex Children's Hospital from around 2010 onwards. And because we'd had this facility, as you can see, from 2010, 11 and 2012, that we were treating modest numbers of children in our children's hospital and achieving quite good rates of reduction in intubation. And in the blue, you can see the total numbers of children we treated. The red shows the number that were intubated. And around this time, there was publications suggesting that intubation rates for bronchiolitis of children who had respiratory support is in the region of 17 to 20%. And so we were able to estimate how many children we had perhaps saved from being intubated, and you can see those numbers in green. And I'll just talk you through a little bit more about the bar chart, just to give you some more context. So our kind of project really started in 2012 when we formed our new acute consultant care team, and that meant for the first time we had dedicated HDU cover by a consultant, and at the same time we opened a children's emergency department, which meant that admission rates started increasing and attendances to our children's hospital started increasing, which explains the jump from winter 2011-12 to winter 12-13. And then we see a significant jump to 2013-14 and 14-15, and that's really accounted for of the success of the children's emergency department, as attendances went up from 22 to almost 25,000 children a year, and also local inpatient unit about 35 miles east of us had closed down, so families were coming more in our direction. And throughout this period, we can see that generally we've maintained a significant number of admissions. There's a slight fall in 2015-16, and I think that reflects the reduced severity of bronchiolitis in that season. So in total, we can see that we've treated 656 infants with either high flow nasocannula oxygen CPAP or BiPAP forms of non-invasive ventilation, and we can estimate that this has prevented 81 bronchiolitis admissions to PICU, and that has saved 240 PICU beds at a time, really from 2011 onwards, that PICU admissions in the United Kingdom for bronchiolitis have been increasing in total by about 600. So we're proud of that achievement, really. If I ask you to move along to the top right-hand corner of the slide, you'll see a list of some of the reasons why NIV proves to be so difficult in children. We know that it's really quite uncomfortable, and that's partly because the masks and the headgears are not really designed for young children, so we've had to adapt. We know obviously it must be frightening, both for the children but also for the parents, who are not only frightened but also tired and upset, and at the same time we are denying both the children and the parents of the kind of cuddles and contact, the ability to suck and explore things with their mouths, which adds to the difficulties. And of course we know that babies and children will remain to a degree hungry and thirsty, and it's difficult to decide what really is causing some of their distress in this age group. So when you put it all together, it's not surprising that it's been a real challenge to make non-invasive ventilation work. And the way we kind of really tackle this is illustrated to some degree in the bottom right-hand corner pictograph, which shows how we've been employing quality improvement methods from 2007, so we've become reasonably good at it, and that the opportunity of changing our team came along in 2012, and so after that, with the change in team, we were able to focus a bit more on things like safety, and introducing various methods such as a ward-round checklist, using the Royal College of Child Health and Paediatrics huddles, and we focused also on how we would teach as well as continue our learning about what we were doing, how we were proceeding, what was working, what wasn't working, and all this required a particular kind of type of leadership which was different to what had gone before. There was an element of flat hierarchy. We were trying to harness everybody's talents. So all this goes into the whole mix. And of course, as with a lot of good stories, luck has a part to play. And so what happened was that we decided that we would seek people who were doing better than us, knew an awful lot more than us, and so we attended the first international paediatric and neonatal NIV meeting, which was held in Barcelona in 2013. And one of the enlightening moments, like a light bulb kind of time for us was when we attended a hands-on session looking at how to actually do non-invasive ventilation in children. And so we listened to them really carefully, and we started adopting some of their teaching. We had to also adapt some of their practices, and that really meant that we had to, as best as we could and as safely as we could, push some boundaries of clinical practice to improve the quality of care. So we used what we'd already known, which was to use, as you can see on the top left-hand corner, PDSA cycles, which are a well-known and hopefully reasonably well-recognised quality improvement tool. And the idea being you plan, then study what you've done, and then act on what you've studied to change the plan. And you keep doing that repeatedly in cycles. And what we did was do that with little cohorts of 3 to 5 patients at a time. And certainly at first, all those patients were being directly supervised by the most senior people in the team, which was the lead consultant, the practice educator, and at least a band 6 level nurse. Now, the advantage of that was also that it meant we spotted our errors really early, and we were able to learn from them early and therefore correct them promptly. And this attitude to learning from our errors and not being too afraid to make them, and accepting that it's part of the human process, that we are always going to make a few errors, but trying to make sure they don't lead to patient harm. And it's kind of encapsulated in the thinking called black box thinking, and you can see at the top of the slide a reference to that if you want to know a little bit more. And really one of the things in order to learn from your errors and to make things successful is having what you might call a growth mindset as opposed to a fixed mindset. And often, certainly for example in my generation, because I'm just gone 50, when we were at school we were often taught as if we had a fixed mindset, and so quite early on we would feel either we're good at something or we're not, and then if we weren't good at it we would kind of get frustrated and we would give up. And we didn't really like to be challenged too much, and if we failed we decided actually if I failed I'm not very good, and we needed to be told that we were smart. Whereas actually in order to succeed, and this is what most successful people know, is that having the attitude that you can learn anything, that you're going to persevere, particularly when you're frustrated, and you're happy to challenge yourself. And if you're going to fail, it doesn't matter, you're going to learn, and you're going to continue trying hard. And the other thing is, if somebody succeeds, we feel inspired, and that's really how we kind of took these things forward. We also decided that we would look at the entire care pathway for this group of patients, starting from attending in the children's emergency department right through to being at home after discharge. And we continued throughout the sort of 5 or 6 years to adapt our team culture to empower the whole multidisciplinary team, and the team was very wide: parents, students, junior doctors, senior doctors, nurses, practice educator, people from outside who we'd learned from. We were fortunate enough to have a RACH team, and we really wanted to create and promote and then also maintain an excellent multidisciplinary team working. And for us, for example, the point at which we introduced the huddle really was a catalyst for helping us with our philosophy to try and include everyone, to maintain a flat hierarchy society, which is so important in allowing people to speak up and empowering them. And we had to therefore listen openly. We learned how to feedback honestly to each other and reminded each other at all times that we always do what's best for children and families. So, by looking at the formal pathway, and also once we started the PDSA cycles, we were able to identify that there were 13 clinical practice parameters and at least 3 equipment parameters that we could work on. And what I mean by work on was to do with inspiration that we got from the British Olympic cycling team. You may remember that in 2012, with the London Olympics, the British cycling team's success was incredibly lauded and very well advertised. And the idea that however small a gain in any individual parameter it was worth pursuing, and that when you added up all the small individual gains, the overall performance is going to be improved. And we applied that really from that inspiration. So here are the kind of 16 areas that we identified, and what I thought would be useful to do would be to go through some of them in a little bit more detail. We showed you what we did and how we achieved improvement. And you'll see that on the right hand side there's some of the list in green, so that we will cover a bit more in the tutorial, in the workshop that's going to happen in the module, and that the 2 areas in blue not really going to touch on too much because they are quite advanced things which, for the purposes of today's presentation, requires a bit more understanding of non-invasive ventilation. So let's start with the left-hand list and high-flow nasal cannula oxygen. Now, the use of heated, humidified, high-flow nasal cannula oxygen was emerging in bronchiolitis. Its use in neonatology had become a bit more established, and there was a little bit more of an evidence base of its use as an alternative to, for example, CPAP and ventilation. And we started using it in about 2009, 2010, and as our experience grew, we pushed the boundaries, and we came along a group of children in whom 2 litres per kilo per minute didn't seem to be quite enough, and that limit of 2 litres per kilo per minute is really being set by the manufacturers, and they have suggested that the flow through their equipment remains laminar and linear, and otherwise would become too turbulent and not create the effectiveness as you might expect. If you jump from 1 to 2, there's a clear benefit, but they seem to suggest that jumping from 2 to 3, they hadn't really tested the equipment, wasn't really designed for that. But what we did was we started really by trying a few children and stepping them up from 2 to 3, just while we waited to get our CPAP ready. It was as simple as that. And while we were waiting, we noticed that for clearly a significant proportion of them, that they didn't seem to need to go to CPAP. Their work of breathing improved, maybe the respiratory rate reduced, the heart rate reduced, maybe the oxygen requirements came down, and so we thought we would look into this a bit more. And this is an excerpt from a poster that was written by Rania Derrick, a 40th medical student who did some work with me, and it shows that we did a retrospective data analysis of a cohort of 232 infants, and that included a cohort from 2014-15 winter, and we're defining winter as October to March, and also 2015-16. So I'd like to talk you through this slide. We'll start off with firstly the top left hand corner and the pie chart, which shows the age distribution between 3-month categories, 0 to 3, 3 to 6, 6 to 9, etc. For the 86 children out of the 193 who received 3 litres per kilo per minute, and hopefully you can see that actually it's fairly evenly distributed across the age ranges, and so there's no particular age group who appear to predominate with a higher flow rate. And then moving across to number 3, you'll see a statement there suggesting that 3 litres per kilo per minute is a more intense therapy than 2 litres per kilo per minute, and hence on the bar chart on the right we can see that there's an increased amount of sedation used, but it is better tolerated than non-invasive ventilation, including CPAP. So the chart on the right, on the left-hand y-axis, shows the mean dose of a commonly used sedation medicine, chloral hydrate, in terms of milligrams per kilogram per day, and the right-hand x-axis shows the mean dose of alememazine, which is a sedating antihistamine, in terms of milligrams per kilo per day. And let's start with the left-hand side, which is patients receiving 2 litres per kilo per minute, and you'll see that they have just under 100 milligrams per kilo per day of chloral hydrate and around 2 milligrams per kilogram per day in the lighter blue bar for alememazine. And that pretty much doubles, so both chloral hydrate double and alememazine double in terms of mean milligrams per kilo per day if they're receiving 3 litres per kilo per minute. And it almost doubles again when children are receiving non-invasive ventilation in the form of CPAP or BiPAP. So the interpretation from our point of view was that patients needing NIV were having really quite high doses of sedation to help them tolerate the treatment, and this was halved if they were having 3 litres per kilo per minute. And so that's quite a significant difference, and the implication of that becomes a bit more relevant when we look at graph number 2. And so this shows on the left axis the number of children that have received different forms of respiratory support, and the x-axis the winter periods, October to March of each season up to 2015-16. And you'll see firstly that there's a dark blue line which increases from 2009-10 winter period, peaks at 2013-14, and this is the line showing the number of children receiving CPAP, and then you can see a dramatic fall in the winter of 2014-15 and a further fall again in the winter of 2015-16. At the same time, you'll see that there's a blue line that increases each successive year, peaking at 2014-15 right at the top at around 80 patients, and that is the number of patients who received high flow. And so the total number of patients receiving high flow has dramatically increased between 2013 to 14 and 15, 16, while CPAP has dramatically reduced. So it looks like we've replaced CPAP with high flow, and This is particularly visible in the kind of slightly greener line, which peaks at 2014-15 around 50 patients. And that is the line showing patients who received 3 litres per kilo per minute of high flow. So it appears that we've been using more high flow than we have CPAP, that patients who perhaps previously were getting CPAP are now getting 3 litres per kilo per minute, and some of those are being stabilised at 2 litres per kilo per minute. And the bottom sort of darker greener line peaking at around, looks like 2014-15 winter season, is the number of children having BiPAP. So, it looks like 3 litres per kilo could be an alternative to CPAP. And so it's interesting to then note in the bottom right-hand corner of the slide, number 4, that vomiting is not a particular problem, either with NIV or with 3 litres per kilo per minute. And that was really the only side effect that we saw. So we had no patients with pneumothoraces, no patients with nasal burns, or any other kind of complications, certainly no one with subcutaneous emphysema, but only vomiting, and none of those had aspirated. So the vomiting was minor. So it looks like as if it also could be safe. So the next slide summarizes our conclusions from looking at this retrospective analysis, and that it's that high flow at 3 litres per kilo per minute appears to be an appropriate escalation, and in terms of higher sedation requirements, appears to be clinically more intensive, but better tolerated than CPAP in terms of how much sedation is required. It is also possible in all age groups, and we think it's safe and reasonably well tolerated, and that's how we've been using it in our unit as a result of this analysis. So this slide is to help share with you the data from the most recently analysed winter season, and you'll see that we've been able to look at the numbers of patients in the winter season of 2016-17, and the red line shows that our use of high flow continues to remain high, and we think as a result our use of CPAP, which is the blue line, has fallen and stayed low, and our use of BiPAP overall is relatively steady given the low numbers. So here we can see a slide showing 2 graphs regarding CPAP, and what they essentially show is that using a CPAP level of 7 centimeters of water pressure improves work of breathing compared to the use of 4 centimeters, and also it's better than going as high as 10. So let me talk you through these graphs. So the left-hand y-axis shows the figures of PTPES stroke minute, and PTPES is product time pressure in the esophagus, and measuring that is a good marker for the work of breathing of all the respiratory muscles. And you can see in the left-hand graph that SB, which is spontaneous breathing, shows a degree of work of breathing, and that is clearly significantly reduced by introducing CPAP of 4 centimeters of water pressure, and even further reduced when we go to 7, but then goes back up again a little when we increase the CPAP to 10. And the right-hand graph shows the work of the diaphragm. So PT-PDI is the pressure time product for the diaphragm, so how much work the diaphragm is doing per minute. And you can see a similar set of lines to the left-hand graph, which is a reduction in the work of breathing of the diaphragm from spontaneous breathing to when you add in 4 centimeters of water pressure, and even further fall when you add in 7 centimeters of water pressure. So this helped us decide that we would use up to 7 centimeters of water pressure, which is a bit higher than most people use in most units around the UK, set around 4 to 6 centimeters of water pressure. So now moving on to really kind of trying to reduce distress in infants who are getting respiratory support. So we looked at how we would consider introducing earlier nasogastric feeding. And so the rationale for this was that it's easy to cause electrolyte imbalance by giving intravenous fluids, particularly with bronchiolitis, where the proportion of infants with inappropriately high ADH levels, which then cause them to retain water, which then leads to hyponatremia, and hyponatremia can be extremely dangerous and cause brain damage. So a particularly serious potential side effect, and particularly in bronchiolitis, an important one, because when people have looked at PICU admissions, almost 40 to 50% of bronchiolitis patients have low sodium levels at the time of admission. So another reason was to obviously make children less distressed, make them less hungry, make them more satisfied. And the added advantage of considering using nasogastric feeding is that if the babies were being breastfed, that the mums could certainly contribute to the care of their children at a time when they're being deprived of so many elements of care by continuing to use their expressed breast milk. Now, the problem we had was that when you look at most guidelines and what most people do, particularly in paediatric intensive care, that for unstable, unintubated respiratory patients, they contraindicate the use of nasogastric feeding. And of course, that's exactly the group that we are looking at. So we decided that we would just go extremely cautiously. And in fact, we started with 30 mils per kilo per day of diarrhea, and after a few patients, we realized that that was very well tolerated and quickly went up to 50. And as we became more confident in its safety, very gradually started increasing it. And you'll remember from the previous slide that vomiting is part of the kind of side effects, or certainly some of the symptoms that we see in children with bronchiolitis on respiratory support, and that this is often cough related, and in none of our patients was there any evidence of aspiration. So we persevered and we continued with using initially diarrhea, and we decided that we would be happy to use milk if the respiratory rate was less than 60, and to consider diarrhea if the respiratory rate was more than 60, and if the oxygen requirements were more than 60%. So please excuse the error on that slide. And with that, we felt that we could safely introduce earlier nasogastric feeding in this potentially difficult patient group. A regular part of the treatment, certainly in intensive care units, is mucus clearance, because mucus plugging is a well-recognised part of bronchiolitis and the cause of acute respiratory failure. So NICE had already said that there was no benefit of the use of hypertonic saline nebulization in routine use for the ward population, but colleagues in children's intensive care and certainly our own nurses felt that they were certainly helping in some of our patients. So although it's now less routine than when we first started it, in that we only use it if thick or plugs of mucus are noticed on nasopharyngeal suction, or if there are radiological changes of significant collapse. And we've decided also that we would not use suction if the child is coughing well and they're over 3 months of age, because nasal blockage isn't always such a problem, but sometimes you can't tell whether the nose is blocked or not unless you've done some suction. So we have basically decided that we would use 3% saline nebulizers as and when indicated on individual patients. And in fact, with the help of our expert physiotherapy team, there were at least 5 patients in whom we ended up using 6% saline nebulizers as a way of helping treat mucus plugging, and we feel that we probably prevented intubation in those patients in whom otherwise there was no alternative to manage their secretions. And in fact, I'm currently waiting for one of my SHOs to write up this case series, because this would be the first time that 6% saline nebulization has been used in bronchiolitis patients and then been documented. Another controversial area was physiotherapy, and you can see on the left-hand side of the slide that a Cochrane database systematic review in 2012 suggested that chest physiotherapy does not appear to have any role in the treatment of children with bronchiolitis who are not on mechanical ventilation, and that's clearly our population. And that furthermore, there wasn't any particular modality or type of physiotherapy that seemed to be any better or worse. The different techniques all equally showed negative results. And so for a long time, traditionally, wheeze was considered to be made worse by physiotherapy. And certainly that is true in our experience. However, our experience also has shown that this is often just short-lived. We were fortunate, in fact, at the time, to have physiotherapists with considerable experience from the Brompton Children's Hospital who were treating wheezy, lower respiratory tract infection children with neuromuscular disease on long-term ventilation. And so they brought over and translated that experience to our bronchiolitis population. And in fact, after the first few goes, we noticed that certainly the tidal volume as measured on our non-invasive ventilators appeared to improve significantly. So we continued the use of physiotherapy, and we've got to the point now where we make a referral and the physiotherapy team will come and assess the suitability to decide for themselves really if physiotherapy is going to be A, tolerated, and B, useful. We move on to the subject of appropriate positioning of infants, and the importance of this really is to reduce the work of breathing, particularly from the core muscles which are related to the posture of the abdomen. And as you can see here on this photograph, the bottom right hand arrow is pointing to a neck roll, firstly, to support the neck and make sure that the airway is open appropriately, and that the bottom left-hand arrow shows a sling which goes underneath the thighs and supports the hips at a 90-degree flexion, and that support really offloads the core muscles. The other important aspect of the positioning is highlighted in the top right-hand arrow, which shows that the bed has been raised towards a 45 degrees. And the other key thing is that you can see we really needed to basically make a homemade solution to this need to position and posture children appropriately, because there's nothing really out there ready-made that we could try. We did have a go at trying some vacuum sandbags, but they were very, very hard surfaces, and we were worried about pressure sores, so ended up just carrying on making things as we go along. Moving on to sedation. Now, very controversial, because probably in the United Kingdom we were one of the very few places outside of the paediatric intensive care unit using sedation in children with acute respiratory failure. So we had to be very analytical in our assessment, and I'm going to show you a few slides now made by Poppy Allport, who's a fourth-year medical student that did an individual research project, and the remit of that project was to answer the question, is it safe to use oral or nasogastric chloral hydrate at the regime that we had been using of 30 to 50 milligrams per kilogram 6-hourly, and oral alemamazine, a sedating antihistamine, at a regime of 2 to 3 milligrams per kilogram every 8 hours for the sedation of children in bronchiolitis requiring respiratory support outside of the PICU. So, as I've said, we're pretty unique within the UK in using both chloral hydrate and alemamazine, and our use really originated from our experience of paediatric intensive care, where it has been used quite significantly, but has now really been overtaken with the use of intravenous sedation medication, which we kind of wanted to avoid, as you might understand. Part of the problem is that the majority of evidence for the use of such sedation is really around the use of sedation in short-term procedures. And added to that, there's not a lot of data about pharmacokinetics and pharmacodynamics. We know that it might be a bit difficult to predict the onset and the duration of the action, and there's an issue with chloral hydrate in particular in a kind of cumulative effect after several doses. So, like a number of reasons to question, is it okay to do what we're doing? So the results here are shown on two bar charts or graphs. Both of them have a left-hand axis, y-axis, showing the dose of chloral hydrate in terms of milligrams per kilo per day, and the right-hand y-axis is the dose of alemamazine in terms of milligrams per kilo per day. And the left-hand bar chart shows that the blue line is the dose of chloral hydrate and the orange line is the dose of alemamazine, and that when we look at CPAP, as pointed out by the left-hand green arrow, the doses of chloral hydrate are almost 250 milligrams per kilo per day and alemamazine 6 milligrams per kilo per day. And when we compare that directly to the dosage of medicines used in 3 litres per kilo per minute of high flow, by the right-hand side of the green arrow, you see that that's quite a significant reduction. So instead of 240 milligrams per kilo for CPAP of chloral hydrate, we're using 180, and instead of 6 milligrams per kilo of alemamazine, we're using 4 That's quite a significant reduction. So that's the first thing to point out. The second thing is that when we looked at the dosages of drugs we're using in patients with BiPAP, we're using really quite high doses, almost to the level of those used for sedating patients with these drugs for invasive ventilation, which we hadn't quite realized until we analyzed this. So clearly this is a message to us that we need to relook at our use of sedation in BiPAP and look to see what else we could do comfortable perhaps, and therefore more easily tolerable without needing such high levels of sedation. And in order to make our assessment and therefore our use of sedation in a more systematic, Janet Lee, our paediatric practice educator, came up with this paediatric non-invasive ventilation sedation scoring tool. And the reason she did that is because the existing sedation scoring tools devised in PICU really required waking up children to see how sedated they are, which is fine if you're just using sedation for a procedure and you want to, for a short time, keep waking them up to make sure they're okay. But if you're using longer term sedation, that's clearly not going to work because the children clearly also need their rest. So she came up with this, and we decided clinically that an acceptable range of 9 to 13 score was the range that we would aim for. So a score of 12, you can see, would include on the alertness, a light sleep, perhaps moving on handling, but certainly resettling, perhaps calm when awake, and occasionally changing position in sleep with clearly regular breathing and the level of support functioning effectively whilst the heart rate consistently within normal limits. Here are the results of Poppy's work. She's collected over 2,700 sets of scores, in fact 2,769 to be exact, in over 100 patients. And the most striking finding is represented in the large star on the right, which summarises that there were no active interventions required to correct any of the sedation score abnormalities. And in fact, 45, so only 1.6% of the scores were noted to be high, so greater than the required 13, which is the upper limit of the score, and half of these returned to normal within a couple of hours without any intervention. Which then leads us to our interpretation of these results, which I think is that the use of oral hydrate and alamemazine with our current regime in the population of children that we treat in our unit appears to be safe. However, it has helped us highlight the need to review the use of our regime in those children with BiPAP, where certainly I think we feel the doses are really a bit too high. Now, at this point, we're going to end this part 1 presentation, and I would encourage you to go on to review part 2, which will begin with the last sort of parameter that we worked on, which was predicting non-invasive ventilation failure, and go on to talk about other aspects of our journey. So with that, I'm going to finish, and thank you very much.